So we're going to talk about fat embolism syndrome in the context of a new patient I'll introduce you to, Ms. A. So she's a 62-year-old who was brought to the ER as a restrained passenger in a motor vehicle accident. She had an initial evaluation that showed a right femur fracture. And when we're talking about fat embolism syndrome, closed fractures are at higher risk. She does undergo prompt surgical repair, but you're asked to see her due to a prolonged need for mechanical ventilation postoperatively. One more question for you. Which of the following signs and symptoms would support fat embolism syndrome? Is it flank pain, leukocytosis, hematuria? Is it petechiae, thrombocytopenia, anemia? Is it chest pain, leukopenia, splinter hemorrhages, libido, abnormal LFTs, and oliguria? Which of those groups of signs and symptoms? You got it. Great. One of my original practice partners is here. We were hospitalists together 15 years ago now in downtown Indianapolis, and our orthopedic group took all the trauma call at the hospital and covered all the race car drivers from the speedway. So we saw some pretty terrible trauma, long bone trauma, pelvic trauma, both risk factors for fat embolism syndrome. He and I were talking this morning, and we think we may have seen 8 cases between the two of us in 8 years of practice together. So it's uncommon, but unless you think of it, you won't diagnose it. So I think worth reviewing. We talked about acute respiratory failure being one of the 4 most common postoperative pulmonary complications. Fat embolism syndrome is a potential etiology for acute respiratory failure. And again, if you don't think about it, you won't diagnose it. Definitely a diagnosis of exclusion, although there are some criteria we'll talk about here in just a second. Fat emboli in and of themselves in pulmonary circulation is actually pretty common, 82%. It becomes the syndrome when you add the signs and symptoms to it. If you look at the ortho literature, there's a wide range of incidence, less than 1% to 30%. And that has to do with the type of fractures they were looking at, the duration of the clinical stay that they were evaluating, and whether people even thought of it as a diagnosis. There are 2 pathophysiologies that were first described 30 to 40 years ago. This isn't a very common entity, at least one that we're not diagnosing very frequently, and so there's not much work that's been done in terms of determining whether really the pathophys is mechanical or biochemical, but these are the 2 standing theories right now. The mechanical is that bone marrow fat cells enter venous sinusoids in some way. They trigger platelet aggregation and fibrin generation, so a clot there, but also they themselves, the fat cells, lodge into the pulmonary artery circulation, and that backup causes interstitial hemorrhage and edema and hypoxia. The biochemical model would say that when bone marrow fat is broken down, that release of free fatty acids is toxic to the pneumocytes and the endothelial cells themselves, and that is what causes the acute lung injury, or the ARDS, that we see in these patients. Regardless of the pathophys, the diagnosis remains clinical. You'll see this again in patients with long bone fracture more frequently if they're closed fractures. Pelvic fractures, for those of you who also take care of more medical diagnoses, you'll see this in patients with pancreatitis, perhaps. Patients who have had liposuction, also a risk factor. There are some potential criteria. These, again, are about 40 years old and haven't changed and haven't been studied much. And when they're studied, different variations on the major and minor theme are put together. So the most frequently stated criteria for fat embolism syndrome is that patients have 1 major and 4 minor criteria. And a majority of you recognize that the petechial rash, respiratory symptoms, or any CNS signs that may be unrelated to trauma are the three major. And you'll see the whole list of minor criteria here. GERD's criteria. This is a brief slide because, again, not much has changed in terms of the treatment or prevention of fat embolism syndrome. If we think about potential preventative measures, corticosteroids is mentioned more often than any other intervention prior to fracture fixation, but really early fixation is the most frequently cited preventative measure for fat embolism syndrome. Treatment is supportive care. So typically these folks are in the unit, typically they're ventilated, they typically require large volume resuscitation. The thing that has changed in the last 40 years or so is that our supportive care has gotten better, and so survival from fat embolism has improved to the tune of mortality now being less than 10%, which was not the case 40 years ago. So again, I don't think you'll think of it unless you think of it. Always worth keeping on your differential fat embolism syndrome, particularly if you take care of those high-risk populations for patients with acute renal failure.